and so we will, anyway, so we've achieved a lot in a short period of time. A lot of it's been done on Zoom. So in terms of disclosures, I have no relevant disclosures. Our funding comes from the Alberta Children's Hospital Foundation, and Libin has also funded this research. For the land acknowledgement, I'd like to take this opportunity to acknowledge the traditional territories of the people of Treaty 7 region in southern Alberta, which includes Blackfoot Confederacy comprising of the Siksika, Bangani, and Kainai First Nations, as well as the Tsuut'ina First Nation and Stoney Nakoda, including Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta, Region 3. So to introduce our research team here, and I'll tell you a little bit about them. I was actually going to have one of our patient experts co-present with me today, but unfortunately, she's been called into the cath lab this morning for a right and left heart cath, but she was able to make a video with the topic that she intended to present on, and I'll show that later. So first we have Michelle here, which you all know. Michelle Potelko is our patient expert who will be presenting later. Connor Haas is another patient expert that has been integral to our team. David Campbell is a medical student who has more creativity in his pinky than I have in my entire being, and so he's been fantastic through this process. Shanda McFadden is a social worker who led our focus groups early in this research, and Mike Slonich, you all know, has gone to a better place, Victoria, BC. So, but he's helped us with the palliative side of our research here. So just a very superficial, brief introduction. Adult congenital heart disease, 30 plus years ago, the majority of patients with congenital heart disease died in childhood. And with this increased survival over the recent decades, congenital specialists are managing a very novel group of people with unique anatomy and physiology. Adults with congenital heart disease have complex healthcare needs that require significant longitudinal medical support throughout their life. Despite all this, and despite the support that they receive, many are at risk for early death. And then we layer this within special considerations for this patient population. So many have medical trauma, PTSD from their childhood, and multiple procedures that have followed them throughout their life. Also, procedures were done with parental consent, and so often they weren't part of those discussions about risks, benefits, and why we're doing these procedures. Many of these patients have already lived through the worst case scenario, and so they have this survivorship mentality as well. And not only that, they've normalized the worst case scenario and made it part of growing up. So that's these are all important considerations for our population here. Just to look at how many people are living with chronic disease and how many people have congenital heart disease compared to other chronic diseases. So of course, we have high numbers. Congenital heart disease is a spectrum of severity. It impacts about 8 in 1,000 births in industrialized nations. But the number of Canadians with congenital heart disease more than triples the number of Canadians with multiple sclerosis, Parkinson's disease, or HIV. And so I think our numbers kind of show that, we have a lot of work to do in terms of helping this population. And certainly there's a lot of opportunity for research to improve their well-being going forward. And this slide is just to show you the massive spectrum there is within congenital heart disease. There certainly is a significant amount of heterogeneity and a wide range of defects in physiology. Our research primarily focuses on the moderate complexity as well as the great complexity, because those are the patients served in the clinic at Peter Lougheed. So next, this highlights the reason for what is underscoring all of our research in this topic, which is the risk of premature death in this population. This data comes from a large Dutch national registry. Over 11,000 patients were reviewed over an 8-year follow-up period, and during that time, almost 200 died. They analyzed the cause of death and the age of patients who died with congenital heart disease, and they found the median age to be 48.8 years, so midlife. And then they further distilled that down into this chart here that looked at the cause of death for these patients to help us anticipate what issues congenital heart disease patients face. So sudden death was just defined as death within 1 hour of the patient's usual state of being, or an unwitnessed death during sleep that didn't have any other explanation. And we see that the median age there was 39 years. Heart failure, we all know what that looks like. The median age was 51, and quite a range in ages there. Other cardiac events that occurred were MI, endocarditis, baffle rupture. And so with those patients, the median age was about 45. For patients who had vascular, that includes stroke, hemorrhage, PE, rupture of aneurysm, or dissection. Those patients were a little bit older, 47 years. And then non-cardiovascular reasons, so that's just including everything else: malignancy, pneumonia, other infections, renal failure, car accident, suicide. And that group of patients was had a median age that was the oldest of 59 years. So we know that there's a risk of dying early, and we do know what these patients die from, but little is known about how they die. So in Canada and Ontario, the Tobler group looked at the end of life experience for patients with congenital heart disease and found that those who were admitted to hospital rarely died suddenly. In fact, the median hospital stay was about 16 days before death. Unfortunately, the majority of end-of-life discussions happened just 2 days before their terminal event. So of the patients admitted to hospital, 42% had previously been declined for transplant, and 56% had recent serious illness requiring hospitalization prior to the terminal hospitalization. So there's ample opportunity for us to intervene for these patients and have these advanced care planning goals of care conversations. I would argue that they should happen even earlier than this, but certainly we have time leading up to their terminal event to ensure that their wishes are respected and their voices are heard. And another multi-site retrospective study, just to highlight, was from the Steiner group in the US. They found that 40% of patients had an ICU admission in the last 30 days of their life, and 64% died in hospital. So again, there's this accumulation of cost at end of life for these patients. And we don't know at this time whether that reflects what their wishes actually would be. If they knew that they were close to their end of life, would they prefer to be at home or in hospital? Or maybe they would prefer to have everything done in ICU. So that's data that we still need to compile for them. The big picture here, though, is that although—
Sorry, can I ask you something? Can you go to the full presentation, because we're seeing also your slides with your notes?
Oh, you're seeing my presenter view?
Yeah.
Oh, I'm so sorry. You guys are watching me read this. I think
Maybe they don't want to interrupt you because you.
No, please. Is it any different now? I've changed the screen.
Nope.
No. No different there, hey?
Sometimes you have to restart the presentation. Go to end show
Yeah.
and
Sometimes it's display settings at the top too.
Okay, sorry, let me just see if I can configure this for us.
sorry for that, but it's it.
No, please, absolutely
Yes.
interrupt me when here I'm thinking just get away with reading some things off that I can't remember, but okay, is it still okay? So just to make sure, yeah, so we've highlighted why we need to do this research. In 2018, the AHA-ACC guidelines recommended that we should be doing palliative care for these patients. But again, we have very little data to guide how we do palliative care and advanced care planning in this population. This is the data that they use to support that that recommendation, and it all comes from Canadian sources, Tobler and Groupman. And just what I want to focus on here is that the literature really focuses on just barriers, facilitators, and knowledge of advanced care planning, palliative care preferences. So we know that patients are interested in learning more about their life expectancy, But at the time that this research was done, only 5% of patients had completed an advance directive and 56 had never heard of it, but almost 90% thought that it was very important. Another thing to highlight is just that we think we're having these conversations with patients, but there may not be the same uptake. And that was found with the second study here that showed that, end of life discussions, 5 patients recalled having those, whereas at almost 50% of healthcare providers said that they routinely have end of life or palliative care, advanced care planning discussions with their patients. So there seems to be a disconnect between what they are hearing versus what they actually understand. And the final study just suggests that we as clinicians underestimate a patient's readiness for these discussions. So many patients are ready and willing to have these discussions, but we think, oh, well, I don't see them close to end of life. There's just things that we can't predict going into the future for people. This is just me compiling more recent data. This comes out of mostly the Steiner group in the USA. And I just want to highlight the cross-sectional survey of 150 patients that Steiner did in 2008, where less than half of the patients had discussed their care preferences with their family and friends. So not only are they not having these conversations with us as healthcare providers, but they're not having it with the important people in their life, the alternate decision makers. Other barriers within the system that exist for advanced care planning and palliative care in young people is just a lack of understanding of their informational needs, poor communication between providers, challenges in navigating patient-family dynamics, and limited formal training in that. Next, what the Steiner group did was after looking at the barriers and facilitators with a survey, they went back and asked participants if they would participate in an interview to talk more about advanced care planning. And the reason I'm highlighting this is because this is actually the first qualitative study on advanced care planning in palliative care and congenital heart disease. And it was published just in November of 2020. So we're so early in our accumulation of data and knowledge to support this. Many patients felt that they needed kind of a multimodality approach to advanced care planning. So written instructions, electronic, in-person checklists, all these things that they kind of identified as important. What I want to highlight from this study was just some quotes from the patient participants. And so what one participant said was, even if it's just to learn about who are some of the people that have a condition like I do that are older than me, and what are some of the things that they go through when they're older? Like, what are some of the things that I can expect as I get older? Because frankly, I don't really know. So it's having those connections with other people that have congenital heart disease that's important. Another participant said, if you give them something that has a gray-haired person on the front, I think it implies, well, these are things to think about, but I don't really need to do it right now because it's not going to affect me yet. And so I think those are critical moments for us to look at what resources are available and how we can bring those resources together for this patient population. Just to highlight, the European Society of Cardiology also put out recommendations for palliative care. They went a bit further and created a framework for us. I just want to highlight what's missing here is they've identified care for the dying and then this tombstone, but part of palliative care and the palliative care umbrella is care after death and care of the family. So I think that this is a good start, but we certainly have work to do here going forward. So our participatory research program, participatory action research, is intended to study and support change within a particular community or group. What we want to do is shift the power from research done to subjects to a collaborative patient approach with our patient experts. And unfortunately, this is novel in the research world. We're kind of seeing the consequences of that in this pandemic, that people really mistrust the science. And they, instead of perceiving themselves as beneficiaries of the research process, they see themselves as guinea pigs. And our hope is that with participatory action, we include patients at all parts of all phases of the research process. So creating the question, generating hypotheses, designing the methodology. Our hope that is that our research will better support our group going forward with their participation. And so with that, I'm going to share, hopefully, another screen here. Michelle was supposed to present with me today, but is in the cath lab currently. So I'm going to play in its entirety her story. And I just think it's really important for you to hear her experience and what she's been through here.
Is there supposed to be audio, Jessica?
Are you guys able to hear that? Sorry.
No, there's no audio.
Ah,
Exciting
how about
stuff.
now?
Oh, there it is.
Okay, let me restart that. My apologies. I'm technologically impaired.
Nope, no worries.
Greetings. My name is Michelle Catelco, and it is an honor to be a patient presenter at Grand Rounds today. Although I wish I could be with you in person, I'm in hot demand and instead have the great fortune of spending the morning with Dr. Har and his team in the Foothills Medical Center's cath lab, getting a total right and left heart cath. Exciting stuff. I'd like to invite you into my journey today. The current chapter we'll find ourselves in is one of transition from countless experiences that I wasn't prepared for to that of open conversation, improved quality of life, and a renewed sense of hope for my future. From mayhem and mess to meaning, a patient perspective on the importance of participatory action research in adult congenital heart disease related advanced care planning and palliative care. I'm 37 glorious years old, and I'm a creative being who transforms life into a musical. Darting my way through life with underdeveloped executive functioning skills, oh indeed I have raging ADHD, is an adventure that I brave with Keith, my ever patient and present husband, who is my rock. Together we are parents to Maddie, our dogter, an adorable rescue pooch. Once upon a time, I was a teacher and community choir director. Life looks a great deal different than it did 5 years ago, and I've come to appreciate the wild ride that is inherent to CHD. CHD took the form of Schoen's complex for me, and I was diagnosed at 3 months of age with a coarctation of the aorta, mitral valve stenosis, and an abnormal tricuspid valve. In 1989, at the age of 5, my coarctation was treated surgically using a Dacron patch, and it has been relatively well behaved since then. Bear with me as we start with the heavier side, the mess and mayhem, if you will, of life lived with CHD. I promise, however, that we will get to the meaning I have found in the middle of all my mess. Life with heart disease is no joke. For me personally, it's a daily choice to push through profound fatigue, shortness of breath, and physical discomfort on exertion. It's a barrage of medication side effects such as dizziness and nausea, gout, acute kidney failure, and atrial fibrillation. It's a daily conscious effort in managing 16 different medications. It's reaching out for help and tapping into resources such as blister packing when the requirements of my disease become unmanageable. It's being vigilant to the amount of salt, fat, carbs, vitamin K, potassium, and liquid I consume so that the needs and limitations of my heart, liver, kidneys, and anticoagulation range aren't adversely affected. In other words, tipping off balance wreaks havoc, and I've been hospitalized with a GI bleed and unstoppable nosebleeds for spikes in my INR due to dietary changes, and I've exacerbated my heart failure by eating foods that are richer in sodium or drinking more fluid than my body could handle. It's deciding if I would rather have my morning tea or soup for lunch. Restaurants, dinner parties, events, vacations, and unique culinary experiences come at a cost. Every decision is a conversation and a weighing of pros and cons and restrictions against just simply living and experiencing life. I am learning to accept my reality and challenge myself each and every day to be disciplined and make the sacrifices and changes I know I need to make. But if I'm truthful, it's overwhelming, frustrating, and rather life-sucking at times. It's meant a financial commitment to co-pay partially covered medications and afford immensely useful but expensive programs like Total Cardiology's Heart Rehab Program, or medical devices such as an INR monitor and test strips. Life with CHD means creating space frequently for specialists and lab appointments, diagnostic procedures, routine tests, and the gathering of information such as my weight, blood pressure, and pulmonary artery pressure readings daily, It's checking in routinely with my heart function and anticoagulation care providers with this information so we can assess and make necessary changes. It's keeping my insurance provider and long-term disability caseworker informed and up to date with the progression of my condition, and it's also meant reworking the budget as my insurance coverage and salary changed. It's traveling abroad while at home via books, recipes, documentaries, recorded music, movies, photos, and conversations with family and friends who have been able to experience other countries firsthand. It's moving from a single family home to a condo with amenities and services close by. It's surrounding myself and my husband with a support system and meaningful relationships that celebrate positive news, but also walk through the valleys and difficult seasons with us. It's keeping my mental health in check and working with a psychologist to manage panic attacks and work through unprocessed trauma and past medical experiences and the grief associated with premature losses. It's finding ways to mitigate stress and conserve energy for what is most important in any given day. If not, over time, I can run the risk of a spike in my INR or an AFib attack needing cardioversion, of which I've had about 9. Shocking, isn't it? All jokes aside, it's that white-hot fear that consumed me the first time I ever had an AFib attack. I thought it was my time and that I was going to die. It's well-researched plans and flexibility to modify or cancel them altogether. At times we joke that it's better not to make plans and just do things in the spur of the moment so my heart and body don't see it coming and self-combust. It's discovering that having a child biologically is too high risk. It's the inability to maintain medical stability for 2 years so we can apply to become foster parents or adopt a child or provide respite care for other parents. It's feeling the discord of joy and pain simultaneously as a sibling welcomes a child into the world, and it's redefining what family is, looks like, sounds like, and feels like. It's meant a great disruption to student learning so that I could go on leave to have my mitral valve replacement surgery. It's meant navigating the aftermath of unsuccessful surgical intervention. It's meant speaking up for myself for 3 straight years until someone listened and investigated my symptoms after surgery. It's meant a diagnosis of severe heart failure and liver congestion that had begun to damage the organs significantly. Life with CHD meant conversations at the age of 33 to decide if an LVAD, heart valve reconstruction, heart and lung transplant, or transitioning to palliative care was the best plan of action for me. It's having experienced the win of being selected as the first patient in Western Canada to receive a CardioMEMS device and being compliant in making the changes that I was asked to make with my medications frequently, at times on a weekly basis, so that we could respond to the data it was generating. It's meant leaving the teaching profession I adored because I could no longer keep up with the mental and physical demands of the job. It's meant resigning from the vibrant community choir of 85 singers I had directed for 11 years, a passion that fed my heart and soul every week. It's meant becoming a cheerleader rather than an active participant in the life I once lived. It's meant letting go of the disappointment and the what-ifs associated with the missed opportunity to plan life in advance. If only we had embarked on these conversations earlier, different decisions might have been made and different timing considered. Over the past 4 years, there has been a shift in my care. Dr. Kier has been relationship focused and driven to listen carefully to my experience and concerns. Life with CHD now means forging an open and trusting partnership with all my healthcare team members. As a result, difficult conversations have been taking place about my disease and its progression, life and living well for as long as possible, and the reality of death and dying. I feel safe and respected during these discussions, which are the hardest and darkest parts of the journey. It's meant defining what's important to me and what values and wishes I hold where my care is concerned. It's meant communicating those values and wishes to my care team, family, and support system so they can speak on my behalf should I not be able to. Life with CHD has meant reevaluating my expectations of self and accepting that I've slowed down progressively over the last 7 years. It's been a daily decision to find new joys, and it's meant a journey of discovery to find a new purpose for my life. The flip side to all that mayhem and mess is this: being 37 years of age with CHD is a miracle. I try not to take a single moment for granted and am thankful for the days I have in abundance compared to other individuals with congenital heart disease. Without the mayhem and mess I've experienced over the last 8 years, I wouldn't have been able to appreciate the unique position in which I now find myself. Dr. Kier and Jessica asked me to be part of their current research because I was surviving through what the study itself is hoping to inform and resource. My story demonstrates the difference between a life lived with and without vital life-changing information. My story demonstrates the difference between a life of missed opportunities, trauma, and regrets, and a life built on knowledge and awareness of what may lie ahead. The invitation to be part of this research team forced me to step outside of my mess, and this in turn revealed its meaning. My story is packed full of experiences, perspective, and insight that is useful, and it needs to be shared. In hindsight, I can see the appointments where difficult conversations were avoided or ill managed, and a total bust in terms of what they were meant to accomplish. I also have a better understanding of why available resource materials were never really offered up. The advanced care planning and palliative care tools currently available are suited to a different audience and different situations, and when I look at the brochures available, I don't relate to them or see myself in them anyway. It's uncomfortable to tell a teenager that becoming pregnant is a matter of life and death, so being safe and smart is essential. So it never came up. It's immensely difficult to tell a young woman and her husband that they may not be able to have biological children. So it was likely avoided until it became too late. And I imagine that it's distressing and nearly impossible without proper training and resources to open up the conversation of life planning, mortality, care wishes, and end-of-life decisions with a 15, 20, 25, or 30-plus-year-old when they are well. And so it's avoided, and patients like myself are handed a green sleeve the day before surgery and asked to make big decisions quickly. It doesn't appear to make sense at the time given our age and current quality of life, but when disease and symptom progression, such as stroke, aortic dissection, deadly arrhythmias, and sudden cardiac death are possible in young and midlife, it's important to figure out how to enter those conversations and make plans and decisions together. And cue the need for research and resource development. Recently, my oh so mature, perceptive, and sensitive 12-year-old nephew underwent an orbital biopsy. It was a very traumatic experience that left him asking to see a psychologist to learn coping strategies. It just so happens that the U of C has a research study in progress for young people who have experienced medical trauma. So he was asked if he would like to go for the 5 sessions they are offering to work through his experience and gain coping tools. He quickly replied, "I'm no guinea pig." There have been times where I have felt just like my nephew, a number or a means to an end in the research process. Being an active participant in research, however, has given me and others as patients a voice and opportunity to share our stories. From these stories emerge themes that have exposed gaps in ACHD care practices and resources. I see PAR starting to take flight in the cardiovascular world. As a matter of fact, I'm participating in a focus group to discuss cardiovascular health research and promotional opportunities tomorrow. If I am offered a seat at the table and can use my experience to inform the future of cardiovascular research and care, you better believe I'm going to be saying yes. PAR has given my struggles meaning. In the wake of losing my teaching career and involvement in community music, it's given me a renewed sense of belonging, value, and purpose. I feel empowered to be an advocate and advisor in the healthcare system. I feel grateful to be able to use my story to help improve the healthcare of patients that are coming up behind me. I feel inspired once again, and I feel like my journey has been worth something. Because of the invitation to be a part of research, I've engaged in and explored deeply the reality of my situation. This has made me brave. I've faced my fears and hard truth and have embraced fully the journey on which I've been placed. I am filled with immense joy and boundless hope for the future. And I'd like to end my contribution today with a challenge to any researcher out there. Find a patient, if you don't already have one on your research team, who is engaged and passionate about their condition and about the future of healthcare. Ask them to be an advisor on your team. I promise it will make all the difference to both them and to your research. Thank you, Jessica, for the opportunity to share my story and be a co-presenter today. And to all of you for the time you've taken and your willingness to listen. To each and every one of you, I say thank you. Thank you for all that you do and for all that you are doing for patients like myself. Because of your care, compassion, curiosity, and commitment to lifelong learning, years have literally been added to my life and to the lives of my peers. Thank you.
Okay, so I think it was just so important to hear Michelle's voice because she's been a huge part of this research along with Connor, and you can see why this is so important to them. I'm just going to switch my screen back. It's unclear if you'll see the presenter view or not. I'm sorry, but let me continue here. Here we go. So, and everyone can see my screen, just shout if you can't. So for our first phase of research, and we have multiple phases within this research, we looked at focus group studies, and this was done with Michelle Cure and Chandra. And what I want to show, what we did was brought in groups of patients with congenital heart disease within specific age ranges and just asked them generally how things are going. And then we took from that themes that came out, and part of those themes was palliative care end of life. And so I'll just relay to you just quickly what was found in this focus group. So despite having good relationships with their cardiologists, many reported feeling uncomfortable bringing up questions regarding life expectancy, fertility, even planning for their careers in the future. And really, their yearly appointments were focused more on the acute medical problems. They attribute this to the busy clinic environment and, you know, the needs to have this physical assessment and medical information compiled to plan for the future. They recounted being terrified of death from a very young age, but none of them wanted to be shielded from that information. 3/4 had never had a life expectancy conversation with their cardiologist and just assumed that they would have a normal life expectancy. And just to quote one patient, I've had some conversations, if I have heart failure, I would get a transplant. I'm just, when it's my time, it's my time. I never thought about those things. My wife gets stressed out and I say, I'm gonna live forever. And I think that just injects some humor into a really heavy topic for this person. If any of us was faced with, you know, a transplant being suggested or being put on the table, that would be a huge life event. But for these patients, it's more of a trajectory. And I think that that's important to attend to for our patients with complex disease. Going further into the focus groups, there was a lot of thinking about dying. So discussions about death were often dismissed by parents just because it's a very uncomfortable topic. I can't imagine as a parent going through something as devastating as serious illness with my child. Some quotes that we've picked out. More recently, life expectancy has been touched on, like liver damage in Fontaine. It's useful to know, so patients want this information. I do think about my life expectancy. I joke I have 5 years to live. Part of me is not joking. I'm scared about it. I think about dying every day and I have a fear of death. When I was a child, I would plan my funeral. And so it just goes to show that death is front of mind for many patients with congenital heart disease. I feel like it's a scary topic. If it was brought up in a regular way, it would be less scary. And then the next quote, I never had this conversation before about advanced care planning, so I'm not sure about how to process it. And again, that just speaks to the need for some tools for us to have these conversations with patients in a meaningful way. So the next phase of our research, we looked into the resources available to patients. And so I'm just going to quickly click through here. And I just want to highlight the different people that you see in these resources here. You'll just see that there's a lot of representation of late life in our advanced care planning resources. Here's a gentleman with chronic illness in advanced care planning who has gray hair. And then if we go more nationally, we go to the advanced care planning website. And again, we see that these conversations are happening with elderly people. So although advanced care planning and palliative care is more often considered a late life issue, all of our resources in education are directed towards older adults. Even with that focus though on advanced care planning in late life, a national inpatient survey found that only 50% of elderly Canadians admitted to hospital had advanced care planning conversations prior to their admission. So even with these resources being directed towards this particular group, these conversations and the tools being used aren't quite translating into practice and into them utilizing these resources. So I'm not going to bore you with the details of all the tools that we looked for to help support advanced care planning in young people. We did find a series of RCTs evaluating family-centered advanced care planning in chronic diseases such as cancer and AIDS, and that was done by Dr. Maureen Lyon. She developed a family-centered advanced care planning survey that was used with patients and their alternate decision maker in a dyad. And I think that's really important because the alternate decision makers are speaking for our patients when they're not able to speak for themselves, and they need to be aware of what our patient preferences are. This is just a sample of what that survey looks like. And so I went back to our patient experts and we went through the survey, and what made them recoil was just the language around dying in the survey. There was a lot of, if you were to be at end of life or if you were dying, what would you want? And so we modified the survey slightly to represent more of a serious illness conversation. So if you were to become seriously ill, who would you want to be speaking for you? Would they know what you want? Just to help reframe this and make it a little less intimidating and scary. I think when we focus on death, it's a terminal event, it's at the end of the line, and a lot of people say, well, hey, I can't do anything about it if I'm dead. But if we refocus things on serious illness conversations, that reframes it for a person that, you know, serious illness is something they've experienced. They've experienced it likely more frequently than the average person. And so they can attend to that in a different way. It makes it a little less frightening for them. And then we added some relevant Canadian advanced care planning alternate decision maker legal resources throughout the survey so that people would know who would be identified as their legal decision maker if they hadn't identified an alternate decision maker, because that's also important for them to know. We came together with our patient experts and looked at different definitions of advanced care planning, and this is the definition that they related most to, and this comes from Dr. Neil Hagen and a group that was looking at advanced care planning in Alberta. So advanced care planning is a process that supports adults at any age and stage of health in understanding and sharing their values, life goals, and preferences regarding future medical care. It's not intended as a one-time event, but a process, and knowledge that decisions change over time. And so then to add to our resources, we created this advanced care planning video, which I'm just going to show you 1 minute of. And I just want you to see how our patient experts invite each other to the conversation and bring this conversation to the people that it's intended for.
I'd like to encourage you that I have been and will most likely be again in the same position that you'll find yourself in right now, or potentially will find yourself in at some point in your health journey. I have a congenital heart disease called Shone's complex. My heart is a little smaller than the average heart, and there's several different complexities that make life interesting.
My name is Connor, and I was born with the coarctation of my aorta that needed to be repaired when I was 2 months old.
I can't do as much activity as the average person.
And so I just wanted to share that video just because now we have a resource that patients can watch that invite them into the conversation, and that came from our patient expert group. The next phase of our research was having patient expert defined outcomes. And so our group came together, and what they want out of this project is to acknowledge the lived experience of those with congenital heart disease. They want early conversations so that they have a greater sense of control in critical situations, that their voice is heard and that promotes their autonomy, even if they can't speak for themselves. They want to normalize end-of-life conversations, make it not terrifying and reduce death anxiety. And they want to explore how to ensure that the right people make decisions for them. They want tools to have conversations with loved ones and healthcare providers, and also maybe set boundaries for those who should not dictate your preferences. We all have those people in our life. And then we went ahead and created a framework, and this framework is quite complex, but I think that complexity just reflects the experience of our patient experts here. So I am going to speak to all of it, and if you can see my screen, you can read along. So this is an open heart concept. You'll see that on the left side of your screen. That's intended to represent the flow of concepts that inform our research. So flowing into the heart are ideals of allyship, intersectionality, and inclusion that are critical to ensuring representation throughout our research process. The right atria and ventricle are a patchwork of concepts that our patient experts have identified as priorities in research. These concepts include health equity, patient partnerships in care, life planning, and anticipation of future needs, with patient-centered education and symptom control. The flow of research continues through the pulmonary arteries that represent the important connections to healthcare providers, primarily the trusting relationships and honest discussions that need to happen, even in worst-case scenarios. The left atria and ventricle represent a patchwork of opportunities within this research. Identified opportunities include engaging with multidisciplinary teams, providing holistic care, identification of transitions in care. So not only transitions from pediatric to adult, but transitions to transplant waitlist or to transplant or to living with heart failure and managing that. Anticipating changing needs, connection with peers, and engagement with the broader congenital community is very important. The second heart represents a repaired heart, and that's the patchwork of the repaired heart, intended to represent the goals and outcomes of the research that we have in this area. The patient experts have identified important outcomes of research, including evidence-based education for healthcare providers to enhance their skill in palliative care, and ensure that there's representation in policy development, equitable care, that's longitudinal, accessible resources developed by people with CHD for CHD. So those are the important concepts that frame our research here going forward. So now we're entering into our phase 4 of our research, and that's currently underway. We have an RCT and narrative analysis ongoing. The research questions developed with our congenital heart patient experts are: do ACHD specific tools resources impact patient participation in advanced care planning? And that's specifically looking at the tools that we've developed and modified or with our patient experts. And what's the impact of advanced care planning and early palliative care for those with congenital heart disease? So we have a partially blinded randomized control trial of 100 participants. There's a control group that gets just the readiness question, which essentially is, are you ready to discuss advanced care planning? And it gives them a drop down of why or why not. The intervention group gets our modified Lion survey and sees the advanced care planning video. And we're looking to see if there's any difference in their readiness with this. The other project that's currently ongoing and currently enrolling patients is the experience of family at end of life and the care after death, which I identified early as an important part of the palliative care umbrella. So I'm currently interviewing patients or alternate decision makers and family members who have lost loved ones to congenital heart complications. The themes, and these themes are early, and so they're going to evolve over time, is a recurrent loss, the loss of employment, pregnancy, loss of friends who have complex disease, and loss of transplant, either being taken off the list or not being put on the list, or deciding later that transplant isn't going to be a benefit. The appointments, again, are very medically focused, and this has been brought forward in this analysis as well. Family at times feel removed or unsupported during transitions. And again, this speaks to the need to have families very involved in the alternate decision maker advanced care planning umbrella. Another theme is surviving one, then many. So, you know, she, in one interview, her daughter survived the worst case scenario several times. How do they know when the next worst case scenario is the terminal one? And then the next was just a sense of agency, having some control over, you know, investigations and follow-up appointments, medical appointments are a big part of their lives. But it takes away a lot of their agency in terms of just being able to be at home with their family when they want to be, or, you know, participate in grand rounds when they're asked to be. So those important pieces kind of have these connections throughout. The next phase in our research, phase 5, will be after our RCT and narrative analysis, which we're looking at measuring the impact of early palliative care and advanced care planning. We want to know how we can measure effective advanced care planning conversations and palliative care, and how do we integrate alternate decision makers into care, and what will advanced care planning look like across provinces and across centers. So we're not reinventing the wheel here. We're actually looking to adapt the Palliative trial, which was a single center RCT that focused on advanced care planning, symptom relief, and attention to spiritual concerns. From that trial, there was a clinically significant improvement in functional scores, quality of life scores from randomization to 6 months, and there was a reduction in depression and anxiety with improvement in spiritual well-being for participants. Importantly, there was no significant impact on rehospitalization or mortality. And I think that just is important to highlight because a lot of people feel that there's this self-fulfilling prophecy that if you talk about death, then it's more likely to happen or the patient's going to give up. And that's been addressed several times in different palliative care literature, that that's not a true reflection. In fact, when people's symptoms are addressed, they feel better, there is a signal that they live longer. The major criticism of this trial is that the palliative interventions were not standardized, so we've created treatment protocols that we'll test with our palliative colleagues and experts to see if we can integrate that into the trial. And this is just a diagram to show you that those who received the intervention did better. So what our plan is, similar to the Palliative trials, we'll randomize 200 patients with complex congenital heart disease and their alternate decision makers, so together, with usual care or care combined with our PAL-CHD interventions. And so we're hoping that there's a signal towards improvement in readiness with our current trials underway, and we'll have some data to support care of the family as well from our narrative analysis. The intervention team will meet with a member trained in the intervention arm, will meet with a member of our team trained in advanced care planning and palliative care, in addition to their usual appointment. And then we'll also at the end have patients and their designated alternate decision makers complete an advanced directive from advancedcareplanning.ca, which is a really great resource because it pulls the different legal considerations from different provinces. And so you complete the alternate decision maker and advanced care planning form based on your province of residence. And then at the very end, the last and final phase of our research, we're hoping to develop an app. And we're hoping to get more funding for this piece because our target group for our intervention is younger and more readily interacts with technology than healthcare providers. We felt that an app would be the ideal opportunity to interact and provide information for our patients. So through this app, we hope to connect those with congenital heart disease to create support networks, provide up-to-date disease-specific information, offer opportunities to record health indicators, and electronically record their advanced care plan and their preferences, which can be shared with their family and their healthcare providers. So that is what our research is building into going forward. And I think that's it. I kind of hurried through the last bit, but I really thought that having Michelle's voice represented in this presentation was very important. So thank you all.
Thanks, Jessica. That was great, very informative. I guess the main buzzword I got from this presentation is readiness. But I think readiness is not only for the patient, but for the team, the care team. So I think that's the main challenge. So how do you know or treat people when to bring this conversation? You don't want it to be too early. You don't want it to be too late. So how do we find that middle ground?
Yeah, I think from what we know right now is patients want to have these conversations earlier. But there is a way to build into these conversations. And so those are the tools that we're working to help, that it's not just a really heavy conversation up front and is as scary up front. And instead, we just offer tools in kind of that will develop into each other so that patients can have their voices heard if they're not able to speak for themselves.
And so where are you at with the RCT? You already started that? You already got
Yeah, we're enrolling patients. We enrolled 5 patients last week with our complex clinic. And so it's exciting, just starting to get the data to roll in here.
For the app part, you know, have you explored getting funding from, Alberta Innovates and people like that?
Yeah, we're in the process of grant writing for that. We were thinking CHIR, but it's a big grant to write, so we're in that process.
Okay. Any questions from anyone? Satish, you always have something to say, so.
I guess I think the patient involvement part is important and it's good. Having done it, I will say that it's sometimes a challenge finding the right patients to do this, because while all patients have their experience, not all are able to necessarily engage as constructively as your patient did. Do you have thoughts on how to select the patient partners as opposed to patients that are good for this type of activity?
So, we invite people to participate. We were hoping initially to have representation, of different experiences. We wanted to ensure that there was representation kind of across the board for people with congenital heart disease who, may be newly Canadian or may have recently immigrated to Canada. And that was the biggest challenge in this research, is because of their experiences and the barriers that they've experienced in healthcare. They're not interested in participating in regular, it's not that they're not interested, they just feel that this research itself doesn't serve them. And so we're looking for different ways for how we can support patients who have had maybe some negative experiences with the healthcare system, or who are marginalized for some reason into our research, because their voice is important to be heard. We've been really fortunate. The people that we've engaged with have been really excited about this research and want to be a part of it. So I can't really speak to the experience of having people who are less engaged, but I think we have to meet patients for where they are. They have other priorities as well, and they may not understand the intent behind the research, but if you bring them in for small bits, you're going to get better outputs.
There's a question from Teresa that says, you see this translate to end-of-life discussions with other disease modalities?
Definitely. I think that there's such a paucity of data for advanced care planning in young people, period, that I'm hopeful that other people with other chronic diseases that are at risk for life-limiting illness or risk for early death, premature death, I'm hopeful that we can translate some of these adapted tools into other chronic diseases.
How do you adapt to, there's different cultural backgrounds that have different thoughts on death and how that goes. How do you handle that?
Yeah, I don't think that we can build a tool to address all that comes up with cultural sensitivity. I think importantly, having representation representation of other cultures with our healthcare providers and identifying people that may connect with patients in a different way, but a meaningful way, is important too. So I don't have any good insight to share with you about that, other than I think that will be something that we unpack as this research unfolds.
Great. Well, thank you very much. Congratulations on great work you're doing. It's always great to see all the incredible stuff we're doing here that we sometimes are not aware of. So congratulations to you, Michelle, and all the group.
Yeah, thank you guys. And thank you for putting up for my technological incompetency, but whatever.
We all have some.